Hello everyone, let's talk about pancytopenia question today. You may be receiving calls from other department regarding pancytopenia issues, and the team usually asks you what to do with this pancytopenia. So pancytopenia can be acute or can be persistent one, and the persistent one usually need more hematological input than the acute one. First of all, ask from the caller, is this pancytopenia acute one or persistent one? And what do you think can be the cause of uh, this pancytopenia in your patient? If they are senior, they usually know the causes of pancytopenia. If they are junior, then you have to bear with them. So if anyone has uh, pancytopenia and you have access to the patient record, go through the blood test and see this pancytopenia is only on this admission or they had long-standing cytopenias. Okay. Secondly, causes. So there are many non-hematological causes of the pancytopenia. You need to rule out the non-hematological causes first, then you need to jump to the hematological one. For example, nutritional deficiencies are common here. You can have B12 deficiency or hematinic deficiency can lead to pancytopenia. Um, if a patient is a heavy drinker, alcoholic dependence can lead to bone marrow knocking out. You can have pancytopenia as well. If a patient has any infection, especially viral infections, they can suppress your bone marrow. They can lead to pancytopenia. Secondly, hypothyroidism can lead to pancytopenia. Similarly, autoimmune diseases, etc. If the patient has any solid organ cancer, think about bone marrow infiltration by the solid organ cancer. It can be a cause of pancytopenia. If a patient is on any medications like antipsychotic medications or any anti-epileptic medications, that can be the cause of pancytopenia as well. So the basic aim is that do not jump to hematological causes of pancytopenia directly in your conversation with another uh, uh, team when they call you for the pancytopenia. You should know the list of causes of pancytopenia and discuss with them. Rule out all these causes first, and then you can think about hematological causes. Yes, hematological causes are many as well. All-over leukemia, lymphoma, um, and the MPNs and the aplastic or PNH, they can lead to pancytopenias. The chemotherapy suppressing effect on the bone marrow is another cause of pancytopenia. So when you know these causes, you will be able to answer the question of the caller regarding the pancytopenia. What test you should request, what profile you should do for pancytopenia. So pancytopenia profile include the routine blood test that we do in our NHS trust for any patient, like full blood count, coagulation screen, renal function test, liver function test, and CRP, along with the blood film. Then we said that hematinic is the cause of deficiency. So request hematinics for this patient, which include folic acid and B12. Then the autoimmune profile, like ANA, thyroid function test, TSH, you should request. Also request a retic count as well. It will tell you whether your patient is having hemolysis or bone marrow suppression. Then the infection marker we have mentioned about CRP, they can send a throat swab if there is any chest infection or throat infection symptoms in the patient, blood cultures, line cultures, depending upon the scenario. If none of these causes are present, all these tests are normal, then you will be thinking about some hematological issue. So then as a hematology doctor, you should see the blood film of the pancytopenia first. In every pancytopenia, you should not miss the blood film. Maybe the blood film has some blast over there, so that you can intervene early and you can do bone marrow biopsy early in them. If they have hematinic deficiency, you will see macrocytosis and hypersegmented neutrophil. But the important thing is that whenever you give advice to someone regarding pancytopenia, your job is to see the blood film so that you should not miss the blast in the patient. If there is any leukemia lymphoma, you will pick that quickly, and the patient treatment will not be delayed. Another causes of pancytopenia are consumptive one, like those patients with chronic liver disease. They usually have big spleen, and they consume all the blood components in the patient body. And if a patient has developed DIC, the DIC is a consumptive process as well, and these patients usually have pancytopenia as well. So the main aim of the this talk is that I have noticed some people in different trusts whose practice is if there is any call regarding pancytopenia, their next step is to do bone marrow biopsy for the patient. This is individual approach. I do not do bone marrow biopsy for the pancytopenia on first call. I always rule out the secondary causes of pancytopenia, the non-hematological causes of pancytopenia first, and then I intervene uh, in the form of bone marrow biopsy in the patient. But I always see their blood film first in the pancytopenic patient. So in my advice, when I'm discussing with the other team, I tell them please request a blood film and write my name in the request section so that the blood film come to me and I will see it and comment on it. So never miss a blood film for pancytopenia. It is it is a pancytopenic blood film. The blood cells will be very less, but you need to check it thoroughly so that you are not missing any blast in it. And as I mentioned, some consultant practice like they request bone marrow biopsy directly on the first call. They think that we should exclude non-hematological causes and hematological causes at the same time. It depends on the individual approach and different trust policies. But to avoid invasive procedure, I usually exclude the secondary causes of pancytopenia first, and then if they are persistent, then we recommend bone marrow biopsy. So always ask first whether this pancytopenia is a new one or persistent one. A new one means there is some acute event in the patient. It can be infection. Patient may have started new drugs like uh, antipsychotic or anti-epileptics. Patient may have become hypothyroid, etc. Or patient may have binge drinking, and alcohol can knock out your bone marrow. If this pancytopenia is persistent, then you have to rule out hematological causes in the patient, and hematological causes are all the hematological malignancies plus chemotherapy. History of the patient is important. So when you are on call with the uh, another medical person who have contacted you for the pancytopenia, ask them, is there any infection in the patient? What is the background history? Any solid organ malignancy or not? Any history of recent radiation? Because radiation can knock out your bone marrow as well. Any anorexia feature in the patient, because anorexia nervosa can lead to deposition of gelatinous material in the bone marrow, knocking the blood cells out. So if you know the different causes of pancytopenia, the common causes of pancytopenia, the list is quite long for the uncommon causes. But remember the common causes of pancytopenia, you can exclude the non-hematological causes of pancytopenia. And you need to know what is the pancytopenia profile, which include full blood count, blood film, virologies, TSH, ANA, hematinics, and retic count along with blood fin, and after that, if everything is normal, then you can send blood for peripheral flow cytometry. I mean the peripheral blood for flow cytometry if there are any suspicious cells, or you can request a bone marrow biopsy for the patient. So this was a small talk regarding the pancytopenia. We will be discussing some topics daily from the registrar. Thank you.